Today we are going to do a short case on thyroid examination. Here we got a 35-year-old lady who was having a neck lump for about 2 to 3 months duration. So here our main focus is to show you that how to get a focused history in this limited time for your examination, and then to do a focused examination on a patient with a neck lump or specifically a goiter, right? So then now we will move to show you that we are going to show you how to take a focused history in this patient. ඔබගේ වයස කීයද? නම පොඩ්ඩක් කියන්න. හරි මොකක්ද දැන් ඔය කියන ප්‍රශ්නේ වෙන්නේ? ගෙඩියක් තියෙනවා. කොච්චර කාලයක් තියෙනවද දැන් ඔය? මාස 5ක් විතර වෙයි. ඒක මෑතකදී ලොකු වුණාද? සයිස් එක ලොකු. එතකොට දැන් ඕක ලොකු වෙනවත් එක්කම ඔයාට කටහඬේ වෙනසක් එහෙම වුණාද? නෑ. රිදෙන්න ගත්තද ඒක? රිදෙන්න පටන් ගත්තා. ඒතකොට කෑම ගිලින්න අමාරු ගතියක් කර හුස්ම ගන්න අමාරු ගතියක් කර තිබ්බද ඕක ලොකු වුණාට පස්සේ? හුස්ම ගන්න අමාරු ගතියක් තිබ්බා. කොයි වගේ වෙලාවටද නිදාගත්තාමද නැත්නම් සාමාන්‍යයෙන් ඕන වෙලාවක හුස්ම ගන්න අමාරු වගේ ගතියක් තියෙනවද? නිදාගත්තාම ටිකක් වැඩි වෙනවා. උගුරේ මොනවා හරි නිකන් තියනවා වගේ නිකන් දැනෙන ගතියක් තියෙනවද? උගුර මොනවා හරි හිර වෙලා තියනවා වගේ දැනෙන ගතියක් තියෙනවා. දැන් මේ ඔය ගෙඩිය වගේ බෙල්ලේ තියෙන ඔය ගෙඩිය දැකපු කාලේ ඉඳලා ඔයාලට නිකන් දැනෙනවද නිකන් වැඩිපුර දාඩිය දානවා, පපුව ගැහෙනවා වගේ කොණ්ඩේ යනවා වැඩි වගේ ඇඟේ බර අඩු වුණා වගේ වෙනසක් ඉපදෙනවා තියෙනවද? බර නම් අඩුනේ. දාඩිය දාන ගතිය, පපුව ගැහෙනවා වගේ දැනෙන ගතිය තියෙනවා. ඒකට කොච්චර කාලයක්? ඒක දැන් මාස 3ක් විතර. එතකොට මේ සම්බන්ධව ඔයාගේ පවුලේ කාට හරි අම්මගේ පැත්තෙන් හරි තාත්තගේ පැත්තෙන් හරි මේ බෙල්ලේ තයිරොයිඩ් ගෙඩි සම්බන්ධ මොන හරි පිළිකාගෙන තිබිලා තියෙනවද? පිළිකාගෙන තයිරොයිඩ් ගෙඩියක් තියෙන්නේ නැද්ද? අම්මගේ තාත්තගේ මොනවත් ප්‍රශ්නයක් තිබිලා නේද? ඔයාගේ සහෝදර සහෝදරියන්ට මොන හරි තිබිලා තියෙනද ඒ වගේ ප්‍රශ්නයක්? එතකොට මේ ගෙඩිය සම්බන්ධව මොන හරි වම වෙනකොට බෙහෙත් පාවිච්චි කරනවා. Thyroxine පෙති ගන්න එකක්වත් හෝමෝන පාලනය කරන්න ප්‍රතිකර්මයක් එහෙම ගන්නෙ නැහැ. Okay. So there is a history. So in summary, she is a 35-year-old female, previously well patient, presented with a neck lump, anterior neck lump for 5 months duration, and she has noted the recent enlargement during the last 3 months period. And then the patient is showing some compression symptoms like difficulty in breathing. At the same time, she is getting the feeling of globus. Otherwise, she is asymptomatic and she doesn't have any history of voice change and no other compression symptoms like dysphagia. Right. And she has not taken any treatment for this issue previously. Otherwise, and clinically she is seems to be a bit hyperthyroid. She is showing some features of hyperthyroidism rather than being euthyroid. So in summary, 35-year-old lady presented with the anterior neck lump for 5 months duration with a 2 months history of recent enlargement with some compressive symptoms. On top of that, patient is showing some features of hyperthyroidism. So basically in thyroid examination, as usual we have to do the inspection, palpation, percussion and auscultation wise we can go in this sequence, or we can do we can access to the patient from the anterior aspect and do the inspection, and then we have to go to the posterior aspect of the patient and do most of the palpation part, and then we can come back into the front of the patient and we can do the rest of the palpation and percussion and auscultation steps in that part. And then the last part is to check for the patient's eye signs and any general features of patient's clinical status of thyrotoxicosis or hypothyroidism. Right. Now first of all I would like to access to the patient from the front to do the relevant inspection findings. Now on thyroid examination, first of all we approach to the patient. The patient should be in sit down position, and then we should have a glass of water for the patient to drink while we are asking the patient to drink it. And then for the first in the first part we have to access to the patient from the front and examine the anterior aspect, and then we have to move to the patient's back and then do the palpation part, most of the palpation part from the posterior aspect, and then we have to come to the front of the patient to examine the eye signs and other general physical signs of hypothyroidism or hypothyroidism. Likewise, we have to move front and back during this examination. Right. So first of all, we see how will you do the examination at the anterior part. Now you can see now the patient is sitting comfortably on a chair, and she is having a lump at the anterior aspect of the neck, and I would like to give her some sip of water. මේ වතුර චුට්ටක් කරට අරගෙන මම කියද්දි ගිලින්න. කටේ තියාගෙන මම කියද්දි ගිලින්න බලන්න. Now you can see when the patient is swallowing that sip of water, the lump in the anterior aspect of the neck is moving up, stays and comes down. So it confirms that the lump is in, there is a lump with thyroid in origin. So it is a goiter. The first comment is it is a goiter. Right. Now we are going to do the inspection part at the anterior aspect. Right. So in the anterior aspect we have to see for any other skin changes. Like here there are no skin changes, like no previous surgical scars. We have to put very particular about that, about previous surgical scars, and no other skin changes like any evidence of recent FNAC. Sometimes if FNAC has been done, you can see some puncture marks over there. Right. And no other dilated veins or any skin changes over the lump. Right. Then from the anterior aspect, I would like to do the palpation part. The first of all, I would like to ask from the patient, make right. Then I would like to palpate the trachea first. So for that, I will keep my the first and fourth fingers at the top of the sternal notch, and I'm palpating the thyroid, the trachea from my middle finger. So when I'm palpating it down, right, I can palpate it, still I can palpate the trachea, and then at the suprasternal notch, I'm pushing my finger over there at the either side of the trachea, So here I can push my finger at the left side of the trachea easily, but when I'm pushing my finger over the right side of the trachea, it's a bit difficult. So it shows that the trachea is a bit shifted towards the right side. Trachea is a bit shifted towards the right, because I can put my finger over there, but I can't put my finger over there very easily. So there can be two reasons. One possibility is trachea shifted to that side, or the overlying goiter is obliterating my the finger when I'm putting over there. Right. That is the comment about the trachea. Right. Then for the rest of the palpation, I would like to go to the patient's posterior aspect to do the palpation part. Right. Now you all can see the patient is having the obvious abnormality in the right side. So I would like to first examine the left side. For that, I would like to press the thyroid gland from left side to from right to left side. So then I can palpate the left lobe very easily. But here I can't palpate the left lobe of the thyroid gland, right? So I can't palpate a nodule over there, right? So it seems to be entirely normal. And then for the palpation of the right side of the gland, I would like to press it from left side towards the right side. So then you can see the lump will become more prominent. So I can palpate it very easily in more detail. So now here I can palpate a lump over there related to the inferior pole of the thyroid, which is uh, 3 by 3 centimeters in size, with well-defined margins and with smooth surface, and it is firm in consistency. At the same time, I can අපිට තව චුට්ටක් වතුර ටිකක් ගිලින්න පුළුවන්. වතුර ටික අරගෙන කටේ තියාගන්න. And here it is very important to know whether I can get below the lump or not. වතුර ටික ගිලින්නද? Yeah. When the patient is swallowing, the lump is moving up, and I can get below the lump when the patient is swallowing, right? And obviously I can get the upper margin of the lump as well, right? So in the palpation, the summary, the left side of the gland is entirely normal, but the right side I can palpate a lump over there, which is 3 by 3 centimeters in size, firm in consistency, with smooth surface and regular margins, which I can get below the lump when the patient is swallowing, and then in that way, that is the comment about the lump on the right side of the thyroid, right? Then the rest of the palpation is the cervical lymph node assessment. As you all know, the cervical lymph node assessment, because a lump in the thyroid or in a goiter, if it is if you are suspecting a malignancy, sometimes it can give rise to lymph node metastasis. So it is paramount to know about a lymph node status of the neck. So the lymph node status of the neck, there are several levels. So this is the submental or the level 1, and submandibular level 2A, and the jugular-digastric, this is level 2B. And then according to the along the anterior border of the sternocleidomastoid muscle, you have the level 3, level 4, and then posterior triangle, posterior to the sternocleidomastoid muscle, the upper part is level 5A and the lower part is level 5B. However, bilaterally we have to examine the whole anterior and posterior lymph node groups. For that, for the palpation, I would keep the patient's head like this, and I would palpate right side first for the lymph nodes. I can't palpate any significant lymph node enlargement over there in the anterior triangle, and as well as in the posterior triangle. Now I'm looking at the left side. I'm looking for the lymph nodes on the submental, submandibular, or level 1, 2, 3, 4, and level 5A and 5B in the posterior triangle. That is the examination of lymph node group. So before I coming at the front, I would like to see whether there are any evidence of protrusion of eyeballs. Usually the protrusion of eyeballs happens when the patient is having Graves' disease or the hypothyroidism. The protrusion of eyeballs can happen. So to see that, I would like to see whether the eyeballs are protruding beyond the supraorbital ridges, like this. So in this level, I can clearly see the eyeballs are not protruding beyond the supraorbital ridges. So that clinical finding is negative, right? So if you are really suspicious about a malignant goiter, especially in follicular carcinomas, which can give rise to scalp metastasis. So they are usually pulsatile scalp metastasis. So in that sort of a situation, you can palpate the scalp like this for any sort of a lump. So with that, before you come in front, you can palpate for the scalp and get to know about whether there are any pulsatile scalp deposits. Right. Okay. Now I am again coming to the front to do the rest of the palpation part in the examination. Right. Now we have done the gland examination as well as the lymph node assessment, and we have palpated the trachea. Now we are remaining with carotid pulse. We have to palpate the carotid pulse, and then we have to see for other inspection findings which can present in the retrosternal goiters, so goiters with some obstructive symptoms. Right. Okay. Now here, so in front of the patient, now I'm going to palpate the carotid pulses, because in a large goiter, the carotid pulse can get deviated. So that is called, if the carotid pulse, we can't palpate the carotid pulse in original location, that is called Berry's signs being positive. Right. For the carotid pulse palpation, in the carotid triangle, I would like to keep my thumb like this. Now I can palpate the patient's carotid pulse well in this side. Right. So it is not deviated, it is in the original position. Right. So in the right side also, I can palpate the carotid pulse like this. So the carotid pulse is there in the normal location. So the carotid pulse in either side has not deviated. Right. And then, so from the beginning, we can demonstrate an inspection finding called Fem-Button sign. The Fem-Button sign is there when you have a obstructing large retrosternal or retroclavicular goiter with evidence of venous obstruction towards the heart from the head and neck, because the thoracic inlet can get obstructed when there is a very large goiter there. So in that sort of a situation, even in resting position, you can see some engorged dilated veins over there in the neck, and they got more, so there will be more engorgement when the patient is elevating both his or her upper limbs parallel to the ears. But the problem in that sort of a situation, sometimes it can be a bit uncomfortable for the patient if they really have features of the venous obstruction due to the goiter. So you can ask the examiner, if the patient is showing some venous obstruction features, you can ask the examiner, I would like to elicit the Fem-Button sign at the latter part of my examination, because it can be uncomfortable for the patient in some situations. Okay, for that, because I detected some retrosternal extension of this goiter even in the resting position, I would like to ask the patient to elevate her both upper limbs to see whether there are any evidence of venous engorgement. So even when the patient is elevating both upper limbs, you can see there are no venous engorgement, obvious venous engorgement over there around the neck region. Right. Now when the lump is completely, you can palpate the complete goiter in the neck, and if you can get below the lump well, you don't need to go for the percussion part. Right. But if you can't get below the lump, it implies that some part of the gland is there behind the clavicle or behind the sternum. So in that sort of situation, it is important to percuss and know at what extent the goiter is extending into the superior medius sternum. Right. So when I was examining the right part of the right side of this patient's goiter, so I got to know that I couldn't get beyond the lump when the lump is at the resting position. So there might be some retroclavicular or retrosternal extension, but when the patient is swallowing, I could get below the lump. So here, because of that, I would like to percuss and see whether the patient was having any retrosternal or retroclavicular extension there. Right. You have to percuss from resonant to dull when you are doing the percussion part. It's dull, it's resonant, it's still resonant. Here it is, so over the clavicle it is bit dull. So there is slight retroclavicular extension, otherwise no obvious retrosternal or extension into the superior mediastinum in this lump. Because here in this side, the thyroid examination was entirely normal. Even I couldn't palpate a goiter there, so I don't want to do the percussion in this side. Right. And then lastly, I can do the auscultation. Here for the auscultation, I can auscultate over the gland for a bruit. In Graves' disease, sometimes you can hear a bruit due to the hypodynamic circulation. And over the carotid, if the Berry sign is positive, that if you can't palpate the carotid, if you are suspecting some carotid deviation due to the enlarged goiter, you can hear a bruit over the carotids also. So the auscultation part, you can do it like that. Right. So that is the complete thyroid examination in a patient. Right. Now that is the thyroid gland examination. Now it is important to know the patient's thyroid status, whether the patient is hypothyroid or hypothyroid or patient is euthyroid. To get to know about that, we can check the eye signs related to the thyroid, and then we can do some general examination to get into know about that. So first of all, I would like to check whether the patient is having eye signs of thyroidoxicosis. First of all, we can see, but at the resting position even, the patient not showing any conjunctival suffusions like chemosis. And lid retraction, you can see when the patient is on resting position. So I can see the eyelashes at normal position and they are not rolled down. So no lid retraction is there. Now how to show whether the patient is having lid lag or not. Now I am asking the patient to follow my finger. When I am moving my finger up and down, the upper eyelid is moving with my finger, moving parallel to my finger. So it's not lagging behind. So there is no lid lag in this patient. Right. And then I want to check whether there is external ophthalmoplegia in this patient, which can happen in the extreme cases of Graves' disease due to some extraocular muscle disease. මගේ ඇඟිල්ල දිහා බලන්න මේක දෙකක් වගේ වෙලා පේනවා නම් කියන්න. Now when I am moving the finger, the patient is moving the eyeballs in a normal way, and patient doesn't complain of diplopia in this situation. So external ophthalmoplegia also unlikely. And by looking at this sclera, I can see the patient doesn't have any evidence of exophthalmos also, because I can only see the sclera above the lower eyelid but not below the upper eyelid. So no ophthalmos is there. So on summary, in this patient's eye sign examination, patient doesn't have any eye signs suggestive of hypothyroidism or Graves' disease. Right. And then the other thing is we can examine the patient's pulse rate. We have to wait for 50 seconds. We have to wait for 50 seconds to check the pulse rate. So here for the demonstration, I would take the pulse rate as 84, and the pulse rate is in normal rhythm and in normal volume. Because to mention about that also important, because in some situations like in thyrotoxicosis, they can have tachycardia, some arrhythmias. So mentioning about the pulse rate, rhythm and the volume is also important. Right. And then finally we can check whether the patient is having clammy hands or not. So usually if they are hypothyroid or thyrotoxic, they can have clammy hands, but here in this patient the hands are not clammy. So, and the other end, so whether the patients to check whether the patients are having tremor, you ask the patient to keep your hands like this and then you can see whether the patient is having a tremor or not. So this patient doesn't show any tremors. So in this patient, in summary, on the examination of the clinical examination for the clinical status of thyroid metabolism, the patient is euthyroid. Now at the end of your thyroid examination, you should give a diagnosis. The diagnosis has mainly two parts. There is your anatomical diagnosis about what sort of lump is there in the neck, and then the patient's thyroid status. Right. So for the first part of the diagnosis, you can have three types of diagnosis. One thing is, it can be a dominant nodule of a multinodular goiter, or it can be a solitary thyroid nodule, or it can be a diffusely enlarged gland. The other side, the thyroid status of the patient can be clinically euthyroid, clinically hypothyroid, or clinically hyperthyroid. So what about this solitary nodule, multinodular goiter and a diffuse enlargement? In a normal patient, you can't see or you can't palpate the thyroid gland. But if you can see or you can palpate the thyroid gland, then it is abnormal. So what is solitary nodule? So in this patient, if you can palpate one part of the gland and if you can't palpate the rest of the gland, so the unpalpable part of the gland is normal, only the palpable part is abnormal. So the palpable part becomes it's become a solitary nodule. So if you can palpate one part of the gland at the same time, if you can't palpate the rest of the gland, so it's a solitary nodule. So then what is a dominant nodule in a multinodular goiter? It happens if you can palpate some part of the gland more prominently at the same time, if you can palpate the rest of the gland also, the rest of the gland also abnormal. It signifies that the rest of the gland also abnormal. So in a multinodular goiter, when there is a dominant nodule, the background, all the thyroid gland is abnormal, thyroid gland is enlarged, at the same time you can palpate a dominant nodule there. So that implies that if you can palpate the whole gland at the same time, there is a more prominent nodule, that is dominant nodule in a multinodular goiter. Right. Then what is diffuse enlargement? Diffuse enlargement usually can happen in physiological goiters, endemic goiters, right, in thyroiditis-like situations. So that whole thyroid gland is uniformly enlarged. Usually it is of the firm consistency. So you can palpate the whole gland, and you can even see when the patient is swallowing, the whole gland is moving up a stage and comes down. So in that sort of a situation, you can palpate the whole gland, homogeneously enlarged gland. That is diffuse enlargement. So for this patient, if you come to this patient on examination, only the right side of the gland, the lower pole, I could palpate a nodule there. But the left side was totally normal, entirely normal. So the diagnosis for this patient's goiter is a solitary nodule. And then in other examination, to see the patient's thyroid status, patient didn't show any eye signs or general examination findings suggestive of thyrotoxicosis or hypothyroidism. So the patient is clinically euthyroid. So my diagnosis at the end of this patient's examination is this 35-year-old young lady presented with a goiter for 5 months duration with recent enlargement for last 2 months. On examination, she found to have a solitary nodule in the right lobe, and she is clinically euthyroid.